Question 1. An established patient is seen by a nurse practitioner, NPP, in an office for management of their stable hypertension. The supervising physician is out of the office at a conference. The service is billed under the physician's provider number. Which billing concept does this scenario violate? A. Split/shared billing. B. Incident to billing. C. New versus established patient rules. D. Teaching physician guidelines. Answer: B. Incident to billing. This question tests the concept of incident to billing, which allows a non-physician practitioner's, NPP, service to be billed under a physician. A key keyword is that the physician was out of the office, which is a major compliance red flag for this rule. Incident to billing requires direct supervision, meaning the physician must be physically present in the office suite, and this scenario fails to meet that critical requirement. For example, if the patient had an unexpected reaction, the physician must be immediately available to assist. Remember this tip: for incident to billing to apply in an office, the physician must be in the house. Question 2. A patient is admitted to observation status at 10 p.m. on Tuesday and is discharged from observation at 9 a.m. on Wednesday. The services on both dates are provided by the same physician. How should these E/M services be coded? A. Report CPT codes 99234 to 99236 for same-day admission and discharge. B. Report an initial observation care code from 99218 to 99220 for Tuesday and an observation discharge code 99217 for Wednesday. C. Report only the initial observation care code for Tuesday, as the stay was less than 24 hours. D. Report an emergency department visit for Tuesday and an office visit for Wednesday. Answer: B. Report an initial observation care code from 99218 to 99220 for Tuesday and an observation discharge code 99217 for Wednesday. This question assesses your understanding of coding for observation stays that span more than one calendar date. The keywords here are the different dates of service: Tuesday for admission and Wednesday for discharge. When an observation stay crosses midnight into a new calendar date, the initial care and the discharge service are reported with separate codes. The same-day admission and discharge codes, 99234 to 99236, are only used when the entire stay occurs on a single calendar date. Always check the calendar dates of admission and discharge to determine if you should use separate codes or the combined same-day codes. Question 3. A physician performs a comprehensive history and exam for a new patient and makes a medical decision of moderate complexity. The physician also spends a total of 50 minutes on the date of the encounter, with 40 minutes dedicated to counseling and coordinating care. Which factor determines the level of this E/M service? A. Medical decision-making, MDM, only. B. Total time or medical decision-making, MDM. C. History and exam only. D. Time only. Answer: B. Total time or medical decision-making, MDM. This question tests the key components for selecting an office E/M code for dates of service in 2021 and beyond. For office and other outpatient E/M services, 99202 to 99215, the code level is selected based on either the level of medical decision-making, MDM, or the total time spent by the provider on the date of the encounter. Since the provider documented both moderate MDM and a total time of 50 minutes, either element can be used to justify the code level. As a coder, you should select the component that results in the higher, yet appropriate, level of service. Think of it as having two paths to the same destination. You can pick the one that best supports the service documented. Question 4. A general surgeon sees a patient in the office for a consultation regarding a recently discovered mass. After the evaluation, the surgeon schedules the patient for a major surgical procedure the following week. Which modifier should be appended to the E/M code for this office visit? A. -24. B. -25. C. -57. D. -59. Answer: C. -57. The concept here is identifying the correct modifier for an E/M service that results in a decision for major surgery. The crucial clue is that the visit's purpose was an evaluation that led to the decision to perform a major surgical procedure. Modifier -57, decision for surgery, is specifically used to indicate that an E/M service on the day of or the day before a major surgery resulted in the decision to perform that procedure. This distinguishes the evaluation from routine preoperative care that is normally included in the surgical package. A handy way to remember is that modifier -57 is for the moment of decision for a major surgery. Question 5. A physician is billing for critical care services. Which of the following activities can be included when calculating the total critical care time? A. Time spent by residents seeing the patient without the teaching physician present. B. Time spent reviewing test results on the unit after discussing the case with the patient's family. C. Time spent performing a separately billable procedure, like placing a central line. D. Time spent on a lunch break away from the patient care unit. Answer: B. Time spent reviewing test results on the unit after discussing the case with the family. This question tests what activities count toward billable critical care time. The keyword is included, focusing on what is permissible according to CPT guidelines. Billable critical care time includes time the physician spends on the patient's unit or floor, engaged in work directly related to the individual patient's care, such as reviewing tests or consulting with other healthcare professionals. Time spent on separately billable procedures or time spent by other providers, like residents, unless it is part of a split/shared service, is not counted. Think of it this way: if the physician is on the floor and focused on that critically ill patient's care, the clock is running. Question 6. A patient is seen for an annual wellness visit, preventive medicine service. During the exam, the patient complains of new-onset, sharp chest pain, which the physician evaluates with a detailed history, exam, and orders an EKG. How should this encounter be coded? A. Bill only for the preventive medicine service. B. Bill only for a problem-oriented E/M visit. C. Bill for the preventive medicine service and a problem-oriented E/M visit with modifier -25 appended to the E/M code. D. Bill for the preventive medicine service and a problem-oriented E/M visit with modifier -59 appended to the E/M code. Answer: C. Bill for the preventive medicine service and a problem-oriented E/M visit with modifier -25 appended to the E/M code. This scenario tests the coding for a significant problem addressed during a preventive visit. The key is that a new-onset, sharp chest pain represents a significant, separately identifiable problem beyond the scope of a routine preventive exam. In this situation, it is appropriate to report both the preventive service code and a problem-oriented E/M code, like 99213 or 99214, with modifier -25 appended to the problem-oriented E/M code. Modifier -25 signifies that a significant, separately identifiable E/M service was performed by the same physician on the same day as another procedure or service. Always remember, when an acute or significant problem is managed during a preventive visit, you can often code for both services, but that E/M code needs modifier -25. Question 7. According to CPT guidelines for office visits, a problem that is undetermined and does not have a clear prognosis but is expected to have a favorable outcome is classified as A. An acute, uncomplicated illness or injury. B. A stable, chronic illness. C. An acute illness with systemic symptoms. D. a chronic illness with severe exacerbation. Answer: A. An acute, uncomplicated illness or injury. This question focuses on the definitions used in the number and complexity of problems addressed element of MDM. The keywords undetermined and favorable outcome point directly to the CPT definition of an acute, uncomplicated illness or injury. This category represents a recent or new short-term problem with a low risk of morbidity and little to no risk of mortality, like cystitis or an allergic reaction. Understanding these precise definitions is crucial for accurately leveling the MDM component. A good tip is to associate acute, uncomplicated with minor, self-limiting problems that are expected to resolve without major intervention. Question 8. A physician and a qualified non-physician practitioner, NPP, in the same group both see a patient during an inpatient hospital visit on the same day. The NPP documents the history and exam, while the physician personally performs and documents the medical decision-making. Under the split/shared visit rules, who can bill for this service? A. Only the NPP can bill for the service. B. Only the physician can bill for the service. C. Both the physician and the NPP can bill for a portion of the service. D. The service cannot be billed by either provider. Answer: B. Only the physician can bill for the service. This tests your knowledge of split/shared visit guidelines, specifically how to determine the billing provider. The rule is that the provider who performs the substantive portion of the visit bills for the entire service. For visits based on MDM, the substantive portion is defined as the provider who performs the medical decision-making in its entirety. Since the physician performed and documented the MDM, they are the one who bills for the shared service, even if the NPP performed other parts of the encounter. Think of MDM as the brain of the visit. Whoever does the thinking gets to bill for it in a split/shared scenario. Question 9. A patient was seen by Dr. Smith, a cardiologist with Cardiology Associates, 2 years ago. Today, the patient sees Dr. Jones, a different cardiologist in the same practice group, Cardiology Associates, for a new problem. How should this patient be classified for E/M coding? A. New patient, because it is a different physician. B. New patient, because it is a new problem. C. Established patient, because it is the same specialty within the same group practice and the last visit was within 3 years. D. Established patient, but only if the visit is for the same problem as 2 years ago. Answer: C. Established patient, because it is the same specialty within the same group practice and the last visit was within 3 years. This question assesses the CPT definition of a new versus an established patient, which is a common point of confusion. A patient is considered established if any physician of the exact same specialty and subspecialty in the same group practice has provided a face-to-face professional service within the past 3 years. The key elements are same specialty, same group practice, and the 3-year window. Since Dr. Jones is in the same specialty and group as Dr. Smith, and the prior visit was within 3 years, the patient is established. The simple rule to remember is, if anyone in the same specialty and group has seen the patient in the last 3 years, they are established. Question 10. A physician is billing an office E/M code based on time. The total time spent was 35 minutes for an established patient visit. The physician's documentation includes time spent reviewing labs before the visit, taking the history and exam, and documenting in the EHR after the patient left. Which of the following activities should not be included in the total time? A. Time spent documenting in the EHR on the same day. B. Time spent reviewing labs prior to seeing the patient. C. Time spent by the medical assistant taking vital signs. D. Time spent counseling the patient on treatment options. Answer: C. Time spent by the medical assistant taking vital signs. This question tests what activities can be included when coding an E/M service based on total time. A crucial detail in the CPT guidelines is that time-based coding includes only the time personally spent by the physician or other qualified healthcare professional, QHP. Time spent by clinical staff, such as a medical assistant taking vital signs or rooming the patient, is not counted towards the physician's total time for billing purposes. The physician's time for reviewing records, performing the visit, and documenting are all valid activities. The key takeaway is that only the QHP's time counts, not the support staff's. Question 11. An internist admits a patient to the hospital. On the same day, a cardiologist is asked to provide an opinion on the patient's cardiac condition but does not take over care. How should the cardiologist report their E/M service for this initial encounter? A. Report an initial hospital care code, 99,221 to 99,223. B. Report a subsequent hospital care code, 99,231 to 99,233. C. Report an outpatient consultation code, 99,242 to 99,245. D. Report an inpatient consultation code, 99,252 to 99,255, if the payer accepts them, or a subsequent hospital care code. Answer: B. Report a subsequent hospital care code, 99,231 to 99,233. This scenario tests the rule about who can bill for initial hospital care. Only one physician, the admitting physician of record, can report the initial hospital care codes, 99,221 to 99,223, for a given admission. Any other physician who provides services to that patient on the same or subsequent days must use different codes, typically subsequent hospital care codes, 99,231 to 99,233, to reflect their role as a consultant or specialist. Since the internist is the admitting physician, the cardiologist must use a code that reflects their different role. A helpful tip is to remember: 1 admission, 1 admitting physician, 1 initial hospital care code family. Question 12. In the medical decision-making (MDM) table, which of the following is an example of a moderate risk of morbidity from additional diagnostic testing or treatment? A. Prescription drug management. B. Ordering an EKG. C. Decision for major surgery. D. Over-the-counter drug management. Answer: A. Prescription drug management. This question requires you to correctly categorize risk within the MDM table, which is a cornerstone of E/M leveling. The element prescription drug management is explicitly listed in the CPT guidelines as an example of moderate risk in the risk of complications and/or morbidity or mortality of patient management column. Decision for major surgery is high risk, while ordering an EKG or managing over-the-counter drugs falls into the low-risk category. For example, initiating a new blood pressure medication involves monitoring for side effects and effectiveness, which carries a moderate level of risk. When leveling MDM, memorizing these key examples of risk, low, moderate, high, is essential for accuracy. Question 13. A physician provides 70 minutes of critical care services to a patient in the ICU. During this time, the physician also spends 15 minutes inserting a central venous access line, a separately billable procedure. How much critical care time should be reported? A. 85 minutes. B. 70 minutes. C. 55 minutes. D. 15 minutes. Answer: C. 55 minutes. This question tests the rule for calculating critical care time when other procedures are performed. CPT guidelines state that time spent performing any procedure that is separately billable cannot be counted toward the total critical care time. The keyword is separately billable, which signals that this time must be carved out. To find the correct critical care time, you must subtract the 15 minutes used for the central line placement from the total 70 minutes, leaving 55 minutes of reportable critical care. A simple rule to live by is, don't double dip. The time for a procedure can't also be counted as critical care time. Question 14. Which of the following is a requirement for a service to be billed by a teaching physician when a resident was involved? A. The teaching physician must be in the hospital building at the time of the service. B. The teaching physician must co-sign the resident's note within 24 hours. C. The teaching physician must personally document their physical presence and participation in the key components of the service. D. The resident must have completed at least 1 year of their residency program. Answer: C. The teaching physician must personally document their physical presence and participation in the key components of the service. This question focuses on the documentation requirements for teaching physician services, a frequent audit target. For a teaching physician to bill for an E/M service involving a resident, they cannot simply co-sign the note. They must add their own documentation confirming their presence during the key portions of the service and their participation in the patient's management. A simple co-signature is insufficient. For instance, an acceptable attestation would be, I saw and evaluated the patient with the resident. I agree with the resident's findings and plan of care as documented. Think of the teaching physician's note as proof that they were an active teacher and participant, not just a supervisor in name only. Question 15. A new patient office visit E/M code 99205 has a CPT-defined total time threshold of 60 to 74 minutes. A physician spends 85 minutes with a new patient on complex issues. How should the prolonged service be coded? A. Report 99205 only, as it is the highest level code. B. Report 99205 and add-on code 99417 once. C. Report 99205 and add-on code 99417 twice. D. Report a higher level unlisted E/M code. Answer: B. Report 99205 and add-on code 99417 once. This question tests the correct use of the outpatient prolonged service add-on code 99417. The key is knowing that this code is used for each full 15-minute increment of total time that extends beyond the minimum time stated in the primary code's descriptor. For CPT code 99205, the minimum time required is 60 minutes. Since the physician spent a total of 85 minutes, you subtract the minimum time, 85 minus 60 is equal to 25 minutes, to find the prolonged portion, which supports one full 15-minute unit of 99,417. Remember to base your calculation on the minimum time of the highest level code, not the maximum. Question 16. An emergency department physician asks a cardiologist to evaluate a patient with acute chest pain. The cardiologist performs an initial evaluation and decides to admit the patient to the hospital under their service, taking over the patient's care from the ED physician. The cardiologist's service is best described as A. Consultation. B. Transfer of care. C. Follow-up visit. D. Concurrent care. Answer: B. Transfer of care. This scenario tests your ability to distinguish between a consultation and a transfer of care. The key phrase is taking over the patient's care, which signifies that the responsibility for the patient's condition has been permanently shifted from the ED physician to the cardiologist. A consultation involves a physician providing an opinion or advice, after which the requesting physician generally continues to manage the patient. Since the cardiologist is now the attending physician for that patient, it is considered a transfer of care, and they would bill using initial hospital care codes. A good tip is to ask, who is in charge of the patient now? If the answer is the new physician, it's a transfer of care. Question 17. For medical decision-making, MDM, which of the following scenarios would be classified under Category 1, independent history taking? A. A physician reviews the patient's past medical records from another facility. B. A physician discusses the patient's case with a consulting specialist. C. A physician obtains the patient's history from the patient's spouse because the patient is unable to communicate. D. A physician independently interprets an EKG tracing performed at an outside facility. Answer: C. A physician obtains the patient's history from the patient's spouse because the patient is unable to communicate. This question assesses what qualifies as an independent historian for the data element of MDM. An independent historian is someone other than the patient who provides history because the patient is unable to provide a complete or reliable history, e.g., due to dementia, altered mental state, or being a young child. Obtaining history from a spouse, parent, or caregiver when the patient cannot participate counts toward this MDM element. Reviewing records or discussing with other physicians falls into different data categories. The key is to remember an independent historian is a person providing information on behalf of an unreliable patient. Question 18. A patient is seen in an office that is physically located within a hospital building. The office is open from 9 a.m. to 5 p.m., Monday to Friday, and handles unscheduled, walk-in patients with acute conditions. A patient is seen for a laceration repair. Which place of service E/M codes are most appropriate? A. Emergency Department Services, 99,281 to 99,285. B. Office or other outpatient services, 99,202 to 99,215. C. Hospital inpatient services, 99,221 to 99,233. D. Hospital observation services, 99,218 to 99,220. Answer: B. Office or other outpatient services, 99,202 to 99,215. This question tests the CPT definition of an emergency department versus an office or urgent care setting. The key details are the limited hours, 9 a.m. to 5 p.m., Monday to Friday, which disqualify it from being a true emergency department, defined by CPT as being available 24 hours a day. Even though it is located in a hospital and sees unscheduled patients, its operational hours mean the services provided are coded as office or other outpatient visits. The location alone doesn't define the service type. The facility must meet the specific CPT criteria. Always check the facility's operational definition, as a hospital-based urgent care is typically coded as an office visit. Question 19. A physician provides services to a patient in a skilled nursing facility, SNF. It is the physician's first encounter with the patient, who was admitted to the SNF 3 days prior by a different, unaffiliated physician. How should the physician code this first visit? A. Subsequent nursing facility care, 99,307 to 99,310. B. Initial nursing facility care, 99,304 to 99,306. C. Nursing facility discharge services, 99,315 to 99,316. D. Domiciliary, rest home, or custodial care services, 99,324 to 99,337. Answer: B. Initial nursing facility care, 99,304 to 99,306. This question assesses the rules for coding initial care in a nursing facility. The initial visit codes are used by the physician who performs the first comprehensive assessment of the patient for that admission, regardless of when the patient was physically admitted to the facility. The key clue is that this is the reporting physician's first encounter with the patient during this SNF stay. Even though the patient was admitted days ago by someone else, this specific physician's first visit is their initial visit, and it should be coded as such. Remember that initial refers to the first visit by the billing provider or group, not the first day of the facility stay. Question 20. When leveling an E/M service based on medical decision-making, MDM, what is the minimum number of categories required to reach a specific overall MDM level? A. One of the three categories must meet or exceed the level. B. Two of the three categories must meet or exceed the level. C. All three of the categories must meet or exceed the level. D. The risk category alone can determine the level. Answer: B. Two of the three categories must meet or exceed the level. This question tests the fundamental rule for determining the overall level of medical decision-making, MDM. To qualify for a particular level of MDM, e.g., moderate, the documentation must meet or exceed the requirements for that level in at least two of the three elements: number and complexity of problems addressed, amount and/or complexity of data to be reviewed and analyzed, and risk of complications. For example, if a visit involves high complexity of problems, moderate data, and low risk, the overall MDM would be graded as moderate, as it meets that level in two categories. The 2 out of 3 rule is a crucial concept to memorize for accurate E/M leveling. Question 21. A physician spends 45 minutes on a subsequent inpatient visit, 99232, which includes 20 minutes on the patient's floor reviewing the chart and discussing care with a nurse before entering the room. Can the 20 minutes of floor time be included in the total time for coding purposes? A. No, only face-to-face time with the patient can be counted. B. Yes, time spent on the patient's unit or floor on the day of the encounter is countable for inpatient services. C. Only 10 minutes can be counted, as floor time is capped. D. No, because the discussion was with a nurse and not another physician. Answer: B. Yes, time spent on the patient's unit or floor on the day of the encounter is countable for inpatient services. This question tests the rules for time-based coding in the inpatient setting, which differ from office visit rules. The key concept is that for hospital inpatient and observation care services, total time includes all time the physician spends on the patient's unit or floor on the date of the encounter. This includes preparatory activities like reviewing records and time spent after the face-to-face portion, as long as it is directly related to the patient's care on that day. Therefore, the 20 minutes of floor time is correctly included in the total time for the service. A helpful way to think about it is that for inpatient coding, the clock for time starts once the provider is on the patient's unit. Question 22. A family physician calls an oncologist to discuss the management of an established patient's new cancer diagnosis and to coordinate the upcoming transfer of care. This discussion takes 10 minutes. How is this activity credited in the family physician's MDM calculation for the patient's visit? A. It does not receive any credit as it was non-face-to-face. B. It is credited under Category 1, Independent History. C. It is credited under Category 2, Independent Interpretation of Tests. D. It is credited under Category 3, Discussion of Management with an External Provider. Answer: D. It is credited under Category 3, Discussion of Management with an External Provider. This scenario tests your knowledge of the data element of MDM, specifically Category 3. The keywords calls an oncologist to discuss the management point directly to this category. When a provider discusses a patient's case, including test interpretation or management plans, with an external physician or other qualified healthcare professional, one not in the same group, it counts as a data point for MDM. This reflects the complexity involved in coordinating care with outside specialists. Remember that MDM credit is given for the cognitive work of medicine, which includes these important professional discussions. Question 23. A patient is admitted for hospital inpatient care on Monday and is discharged on Wednesday. Which E/M code category would be inappropriate to report for this stay? A. Initial hospital care, 99,221 to 99,223. B. Subsequent hospital care, 99,231 to 99,233. C. Hospital discharge day management, 99,238 to 99,239. D. Observation or inpatient care services, including same-day admission and discharge, 99,234 to 99,236. Answer: D. Observation or inpatient care services, including same-day admission and discharge, 99,234 to 99,236. This question tests your understanding of when to use specific code sets based on the length of a hospital stay. The key detail is that the patient's stay spanned multiple calendar dates, admitted on Monday and discharged on Wednesday. The codes for same-day admission and discharge, 99,234 to 99,236, are exclusively used when a patient's admission and discharge occur on the same calendar date. Since this patient's stay crossed over several days, using the same-day codes would be incorrect. Instead, an initial care, subsequent care, and discharge day code would be used. The takeaway is to always check if the admission and discharge fall on a single calendar date before considering codes 99,234 to 99,236. Question 24. A patient comes to the office for follow-up of their diabetes. During the visit, the patient asks the physician to remove a bothersome skin tag from their neck. The physician performs the E/M for the diabetes management and then removes the skin tag. Which modifier should be appended to the E/M code? A. -57. B. -59. C. -24. D. -25. Answer: D. -25. This question evaluates the correct use of modifier -25 in the context of a minor procedure. The scenario involves two distinct services, the E/M for diabetes management and the skin tag removal. Modifier -25 is defined as a significant, separately identifiable evaluation and management service by the same physician, on the same day of the procedure or other service. Since the E/M for diabetes was a medically necessary and distinct service from the minor procedure, modifier -25 should be appended to the E/M code to allow for payment of both services. A good way to remember is, if you can justify the E/M visit even if the procedure wasn't done, you likely need a modifier -25. Question 25. A physician provides a service that is a legitimate E/M service but for which there is no specific CPT code available. An example would be a lengthy, medically necessary team conference about a patient's complex care plan, where the patient is not present. What is the correct way to report such a service? A. Use the CPT code that most closely approximates the service. B. Do not bill for the service as there is no specific code. C. Use the unlisted evaluation and management service code, 99499. D. Use the lowest level office visit code, 99,211. Answer: C. Use the unlisted evaluation and management service code, 99499. This question tests the appropriate use of unlisted procedure codes. The key concept is that when a performed service is not described by any existing CPT code, the correct course of action is to use the designated unlisted code for that section. For E/M services, this is code 99499. Using an approximate code is improper, and not billing for a legitimate service is incorrect. When using an unlisted code, it is critical to submit a detailed report explaining the service provided to justify its medical necessity and complexity to the payer. Think of the unlisted code as the none of the above option that requires you to show your work.